How do we diagnose Alzheimer's disease? Well, you check the memory. And the most common thing is something called the Folstein mini-mental, and it's kind of interesting. Marshall Folstein is a guy up in Boston at Tufts, and about 7 years ago, he decided to go ahead and patent the Folstein mini-mental that had been out for 20 years. So now technically, if you do one, you're supposed to send him $1. And it brought up all the ethics about it because we have 30 years of data on it. But it's just it's a good memory screening test. It's one that I do, but I do it not to diagnose. I use it to track on a year-to-year basis because it's reliable and it's predictable. The average person will drop down a couple points a year who's not treated, so it kind of gives you an idea of where they are. The other one that I really like is a clock draw. It's really difficult to draw a clock. You have your patients draw a big clock, and then you write in all the numbers, and then we tell them to set the time at 10 after 11. And it's a very hard task to do. And it just gives you a lot. You can see how they plan. You can see where they put their hands. And it's interesting because I got 3 boys, twins that are 12 and an 8-year-old, and I don't think they know how to do a clock anymore. You know, everything's all digital, so I'm not sure we're going to be able to use a clock test, 20, 30 years from now. And so there's some other testing, but the gold standard is neuropsych testing. A Folstein mini-mental was basically designed for people with a 10th grade education. So if you have somebody, I took care of a Nobel laureate, of physics, really, really, really smart guy. If you give him the Folstein mini-mental, he scores perfect, but he still had advanced Alzheimer's. And so neuropsychologists are able to do a little bit more sophisticated testing. And for people who it's unclear what's going on, it's always worth doing. 1 in every 10 patients over the age of 65 are going to be, who are screened, are going to have Alzheimer's. And again, it basically goes up as they start to age. So when we look at a brain, Alzheimer's, we think of a temporal hippocampal illness, but it's a global illness. And I'm sure most people haven't seen many brains, but the sulci are very big, meaning that the brain has shrunk so that the gaps between them seem bigger. And you could see in this area, you'll see a lot more of it. This is the temporal area where Alzheimer's, where our memory tends to happen. These are the ventricles. And this is when we talked about normal pressure hydrocephalus. The cells here have gone away, so these get bigger. And then the radiologist says, I can't rule out normal pressure hydrocephalus, and it kind of puts you in a bind. But these areas here, this should be here, and this should be here, it should be plump. And so you see the marked atrophy of the brain that we see with Alzheimer's. The pathophysiology, this is where I lose everybody, but this is the important stuff, because this is where the future is. We've known about the plaques since Dr. Alzheimer's. So over 100 years we've known about these plaques. But not all plaques are created equal. There's what we call diffuse plaques and neuritic plaques. A diffuse plaque is the amyloid plaque that's been deposited in the brain. The neuritic plaque is the plaque that has inflammation. And it's the ones that get inflammation that cause the cell deaths. Why is this important? Because if we could prevent it from going from a diffuse plaque to a neuritic plaque, we could prevent the cell from dying and thus preserve some of the memory. The forgotten child is the tangles. Almost all the research is done on the plaques. There's only a little bit on tangles. And it's, part of me being a skeptic always says, I hope we're right. Because there's a lot of times where we think things are what they are. In the 90s, everybody was treated for homocysteine. If your homocysteine was high, we treated you. And then we found out that if we treated your homocysteine, we made you worse. Why did we treat you? Because if you had an elevated homocysteine, you had an elevated risk of Alzheimer's, stroke, all kinds of things. So we treated it, but it didn't make a difference. So there's something else somewhere earlier in the pathway that we haven't been able to figure out. And that's always our concern with Alzheimer's, is could it be something else, and the plaques and tangles are just the end result, and our real treatment needs to be a little bit earlier. And with time, we'll be able to figure that out, because we now have medications that can stop antibodies against the plaques, and we're working on some medications for the tangles, and we'll know. But there's no question, if you stain the plaque, we have these sophisticated PET scans now, and you could stain the plaque, and you could take somebody in their 60 and they have X amount of plaque, and you watch them age, and it increases, and those are the people who go on to develop Alzheimer's. So we're able to start diagnosing these a lot earlier before people have symptoms, but the problem is what do we do? You know, what's the point of getting a $2,000 test if we can't do anything? And that's why we're hoping that with time, we'll get effective treatment so we can identify people earlier. So this is the amyloid precursor protein. This is the protein that gives rise to the amyloid plaque. And basically what it is it's a transmembrane. It crosses the membrane. This is a cell, and this is the protein. In order to form the plaque, it needs to be cut here and cut here. And if it's cut there, then what happens is it forms the plaque. All those little pieces came together, and this forms the plaque. So if we could cut it in the middle, we could stop it, or if we could stop the cutting here or the cutting there, we could prevent this plaque from forming. And this is what it looks like in the cells itself, the plaque. The tangles are a little bit different. There's this protein called tau, which kind of stabilizes. If you think about it, it's like a railroad track, and you have these braces that go across, and it keeps it nice and stable. And they end up getting too much phosphorylation on it, and it starts to fall apart, and it forms these tangles. And under electron microscope, the tangles are actually quite beautiful. And we don't know which one is the causative agent. Can we treat one and prevent the disease? Do we have to treat the other? Do we have to treat both? And unfortunately, we don't have many things that we've learned about with regard to the tangles yet. So when somebody has Alzheimer's disease, there's a natural progression that we've come to learn. It's different in everybody, but there's generalizations that can be learned. The first thing we talked about is the cognitive symptoms tend to be a little bit of memory problems, a little bit forgetful, and then usually a little bit later we make the diagnosis, and as the disease progresses, they start to get a loss of functional status, harder for them to take care of themselves, the husband, the wife, the kids need to take care of them a little bit more, start doing the checkbook. As it progresses, we tend to start to get behavioral problems, and this is basically what I do at Terracina. It's, you know, if you take 30, 40 people with Alzheimer's, put them together, not everybody gets along, and part of, you know, a geriatrician is trying to get everybody to get along, because sometimes it's related to the illness, sometimes there's little things that we can do, and in the very late stages is where again nursing home placement ends up. And you know, if you're 90 years old and you get diagnosed with Alzheimer's, not too bad. If you're 60 years old and you get diagnosed with Alzheimer's disease, it's really tough, because if you're healthy, you'll live through the whole spectrum of the disease. And I've taken care of a lot of patients who, you know, end up basically not able to talk, not able to get out of bed. And if you're healthy, it can go on. And usually from diagnosis to death is somewhere between 8 and 12 years.